Hamizah, are you ready? Ready, eh?
InsyaAllah.
Okay, Assalamualaikum and very good morning to all. Here we have Dr. Faidul, Dr. Rafiq, and apa, four MOs here also, including Razi. Alright, so today our CME is by Hamizah. The topic is approach to croup and bronchiolitis. Okay, so Hamizah, you
Yeah.
may share your screen.
Okay. Assalamualaikum and good morning, everyone. My CME today is approach to croup and bronchiolitis, supervised by Dr. Anas. Okay, let's start with viral croup. Viral croup is a viral inflammation of the larynx, trachea, and bronchi, also known as laryngotracheobronchitis. It typically occurs in young children between ages of 6 months to 3 years old. Most common cause is parainfluenza virus, which is about 74%. Influenza virus type A and B, adenovirus, enterovirus, measles, mumps, and rhinovirus. Okay, the anatomy of respiratory tract, including of upper respiratory tract and lower respiratory tract. Upper is a nasal cavity, oral cavity, pharynx, and larynx. Lower respiratory tract is trachea, bronchi, smaller bronchi, bronchioles, and bronchioles. Bronchioles and alveolus. Sorry. So the pathophysiology of laryngotracheobronchitis is started when the virus invades the upper respiratory tract, which is will result in upper respiratory tract symptoms such as coryza and fever for first few days, and then the virus will cause increasing of secretion, pain and edema of and narrowing of the lumen of the trachea, causing inflamed of vocal cords. The narrowing of the trachea will cause the stridor and causing O2 retention and turbulent noisy airflow, causing stridor punya sound. Clinical manifestation, uh, patient will came with low-grade fever, cough, coryza for 12 to 72 hours, followed by increasingly bug-like cough and hoarseness. Stridor may occur when excited, at rest, or at both, depending on the severity of the illness. Respiratory distress will vary according to the patients. So this is normal layering, trachea, the vocal cords. This the below pictures is the inflamed larynx, swelling of vocal cords and surrounding structures. Hello.
Dengar, dengar.
Dengar?
Continue, Hamizah. Hamizah,
Okay,
okay ke
okay.
Hamizah?
Okay. Okay. Croup is a clinical diagnosis. Study shows that it is safe to visualize the pharynx to exclude acute epiglottitis, retropharyngeal abscess, etc. In severe croup, it is advisable to examine the pharynx under controlled conditions such as ICU or OT. Neck radiograph is not necessary in all cases unless the diagnosis is in doubt, such as in the exclusion of a foreign body. So differential diagnosis is epiglottitis. So usually dalam epiglottitis there will be absence of barking cough. Epiglottitis is rapid onset lah, tak macam croup. Croup usually develop dalam 18 to 72 hours kan. So patient usually ada anxiousness juga. Child will be in sniffing position lah, sebab usually child will assume that sniffing position tu boleh maximize the patency of the high grade fever, since it is more of a bacterial infection. So patient will be ill looking and difficulty swelling, also having drooling of saliva lah, sebab pain dekat dia punya epiglottis. So kalau foreign body airway obstruction, there will be history of sudden onset of choking. Previously, child was well, tengah makan ke apa, and then suddenly develop a stridor, barking cough macam tu lah. So clinical assessment of croup ni Wagener dalam pediatric protocol lah. Jadi divide into three: mild croup, moderate croup and severe croup. Mild croup is ada stridor at rest or only when agitated, tapi tak ada tachypnea, no retractions, no altered mental status. Kalau moderate croup, usually at rest pun dah ada stridor, started having mild tachypnea, mild retractions, tapi no mental status change. Severe croup usually ada stridor at rest, the respiratory distress with marked and severe retractions, also having altered mental status. Usually severe groups ni requiring either NIV ataupun intubation. This is Wesley Croup severity score. Sama je, basically dia punya clinical features still guna level of consciousness, cyanosis, stridor, entry dengan retractions. So dia ada scoring dekat sini. Kita boleh tengok based on score dia punya severity lah. So for indications of hospital admission, usually moderate to severe groups. Patient yang less than 6 months old, ada poor oral intake, toxic or sick appearance, and tengok dia punya distance from hospital. Kalau long distance, reliable transport tu tak ada, so advisable for admission. This is algorithm management of group. Kalau mild, usually outpatient, kita boleh bagi dexamethasone oral 0.15 kg 15 kg per single dose lah. May repeat to 12 and 24 hours, or oral prednisolone 1 to 2 mg per kg stat. If the child develop vomiting, boleh bagi nebulized budesonide 2 mg single dose. And reassess shortly after. If shows improvement, can discharge home. In moderate viral croup, usually kita admit this patient, boleh bagi dexamethasone oral or IV 0.3 to 0.6 mg per kg single dose, and or budesonide nebulized 2 mg stat and 1 mg 12 hourly. If no improvement or deterioration, dia bagi nebulized adrenaline 0.5 ml per kg. Dilution 1:1000 lah, maximum dose 5 ml. So kalau no improvement or deterioration, memang kena intubate ataupun ventilate lah. In severe patient, inpatient, usually kita bagi nebulized adrenaline 0.5 ml per kg, or IV dexamethasone 0.3 to 0.6 mg per kg, and nebulized budesonide 2 mg stat and 1 mg 12 hourly, also oxygen supplement.
Hamizah, can go back to the Wesley score tadi?
Yang ni tu.
Can go.
Ini. Wesley score.
Next page.
Ni.
Okay.
So usually kalau score less than or equals to 2 is severity dia mild lah. Patient usually keep occasional bulky cough, no stridor at rest, mild or no retractions. Dia hampir sama dengan Wagener lah. So home treatment, symptomatic care including antibiotic, mist dengan oral fluid. Outpatient treatment macam sama macam kita punya PITS protocol. So boleh bagi oral dexamethasone juga. Kalau moderate, score dia 3 to 7, frequent bulky cough, stridor at rest, mild to moderate retractions, but no or little distress or agitation. Boleh bagi single dose of oral dexamethasone 0.6 mg per kg, and dia bagi nebulized epinephrine lah, according to Wesley punya ni dari up to date.
Okay. Alright. Continue. Basically, the last two slides are the most important, especially the CPG flowchart algorithm, management of mild, moderate, and severe croup. and also the score. This is basically to support your apa severity punya classification and your tally your management. Proceed bronchiolitis.
Okay. Next is bronchiolitis. Etiology and epidemiology usually common in infants 1 to 6 months old. Common cause is respiratory syncytial virus. Dekat Malaysia ni. So dekat Malaysia ni dia endemik sebenarnya, tapi peak number of cases usually dekat hujung tahun November, December and January. Katanya associated with rainy season. Other pathogen that may cause bronchiolitis is rhinovirus, parainfluenza virus, human metapneumovirus, influenza virus, adenovirus, and also coronavirus. So usually bronchiolitis ni occurs when viruses infect the terminal bronchiolar epithelial cells, causing direct damage and inflammation in the small bronchi and bronchioles. Dia sama juga macam croup, tapi dia tempat dia berbeza lah. Dia jadi dekat bronchioles. So dia akan jadi edema, excessive mucus, ada slough, uh, lead to obstruction of small airways, athalatosis. This lower respiratory tract symptoms usually occurs dalam 1 to 3 days. So clinical manifestation, child who came with mild coryza, low grade fever and cough. The kidney ada chest wall resection, wheeze and respiratory distress subsequently develop lepas tu. On auscultation, we may listen to fine crepitations and sometimes ronchi. So majority of children with viral bronchitis has mild illness, and about 1% of these children require hospital admission. So this is on auscultation, child will present macam ni lah. Ada crepitations, ada ronchi. Ni audible whistle.
Hamizah.
Ya?
Tadi your voice are broken. Okay. Ulang balik boleh?
Ulang balik dengar sound balik. Okay.
Ha. Tak ada pun. Tak ada sound lah. Ada sound mana? Okay, tak apa, proceed.
Oh, tak dengar tu. Sorry. So kita kena anticipate risk factor for severe disease, severe bronchitis. Risk factors for severe or complicated bronchiolitis include patient yang premature, which is born at the age of less than or equal to 36 weeks, low birth weight, age less than 12 weeks, chronic pulmonary disease, particularly bronchopulmonary dysplasia, anatomic defects of the airways, hemodynamically significant congenital heart disease, immunodeficiency, neurologic disease, and passive smoking lah usually. Kena tanya lah dia selalu dapat dari mana, kena asap rokok ke. So ni guidelines for hospital admission in viral bronchiolitis. Kalau home management, hospital management, if patient age less than 3 months, ada toxic looking, chest recession is moderate to severe, central cyanosis, ada wheeze, crepitations on auscultation, difficult feeding, poor oral intake, ada apnea, oxygen saturation drop less than 93%, and high risk group yang tadi kita discuss. Severity assessment. Consensus definition for severe bronchitis are lacking. In general, we consider severe bronchitis to be indicated by any of the following: persistently increased respiratory effort, which is the tachypnea, ada nasal flaring, intercostal, subcostal, suprasternal recession, using of accessory muscle, ada grunting, and the frequent assess of the patient, at least 5-15 minutes interval. So if patient ada hypoxemia, SpO2 less than 95%, apnea, acute respiratory failure. So if non-severe bronchiolitis, usually kita cakap the absence of all of the above lah. So yang ni semua based on clinical judgement sajalah. Saya cakap sini, a repeated observation are necessary to adequately assess disease severity because examination findings may vary substantially over time. So, imaging, chest X-ray findings, hyperinflation the most common. Sometimes boleh ada segmental collapse or consolidation or lobar collapse or consolidation. So management of bronchiolitis in ED ada mild, moderate, severe. So kalau mild tu usually kita discharge with feeding advice, safety netting advice and deflate. So contoh kita educate the parents yang bronchiolitis ni over time dia virus infection, so over time dia boleh subside. Tapi kena educate the parents regarding the severity lah. So when to come to ED. So if moderate, usually kita akan start oxygen via nasocannula at least to maintain SpO2 more than 90% if needed. If severe, oxygen memang diperlukan, and then patient memang kita stop feeding, start IV fluid, and if kena intubate then proceed for intubation lah. So differential diagnosis, bronchiolitis usually ada low grade fever. Ni bronchiolitis versus viral wheeze versus asthma versus pneumonia. So in bronchiolitis usually low grade fever, patient will become unwell kalau severe, ada recession or tachypnea. Usual age range is birth to 12 months old, cough dia high pitch and ada wheeze. In viral wheeze, fever boleh ada maybe but usually low grade lah. Patient was previously well, recession and tachypnea boleh ada. Usual age range is 1 to 7 years old lah. Cough, yes, and tight lah. Wheeze ada juga. Asthma, usually tak ada fever. Patient was previously well, ada recession and tachypnea. Usual age range is over 5 years old. Ada cough, boleh ada wheeze. And pneumonia, boleh ada semua ni lah.
Hamizah, this one you taken yang from RCEM tu kan? Royal College of Emergency Medicine UK tu kan? Okay. Just take note that the age, sometimes there are a bit difference between the age of asthma. For Malaysian, I think mostly pediatrics, they take above 2 or 3 years old lah. Kan? Usually if above 2, they can already, sometimes they start to label as bronchial asthma, especially the asthma API or interval symptoms are very strong with positive family history lah. Okay, but I think got one more slide kan, Hamizah?
Any prevention saja doktor.
Okay.
So since bronchiolitis is from viral infection, so general strategies to prevent bronchiolitis is hand hygiene, minimizing inclusive exposure to cigarette smoke, avoid contact with individual with respiratory tract infections, and no influenza immunization. Ni yang palivizumab ni based on research sebelum ni lah cakap immunoprophylaxis with palivizumab may decrease the risk of hospitalization in infants with bronchopulmonary dysplasia, patient yang high risk lah. Tapi saya tak sure kita apply ke tak kat sini. Okay, this is my references.
Okay, thank you, Hamizah. By the way, thank you very much, Hamizah. Despite you are unwell, baru positive, then you still want to proceed with presentation. Thank you very much. We appreciate that.
Thank you, Dr.
I just want to comment a few things. Number one, okay, buka balik slide boleh? Can please share your screen? Just run to the algorithm again.
Croup.
Okay, basically, in summary, in this topic, what Hamizah presented was actually there are two main things lah. Because in children, there are two approach. Number one, approach to wheezing children. Okay, wheezing children, usually commonly we see bronchiolitis, asthma, pneumonia with bronchospasm, reactive airway disease, multi trigger, which are so many terminologies lah kalau kita ni kan. Then number two is approach to stridor. Okay, so Croup is come under stridor lah. So management of Croup, I think number one is history. You must take adequate history lah, because it will differentiate Croup. The three main things that you have to differentiate whether it's a Croup, is it acute epiglottitis, or foreign body airway obstruction lah. So there are three main things. And of course, for the smaller, younger neonate, sometimes the first 3 months, they also can have that what we call laryngomalacia kan, laryngomalacia kan, that is quite common also. So for Croup, I think this is the most important slide that we must keep in our mind. Kalau tak ingat pun, I think you can refer to pediatric punya protocol kan. Okay, just take note that for mild, some of us, we tend to give both steroids and also budesonide kan. So, but actually it's all kan. You can either give NAP, or most of us prefer to give NAP budesonide sajalah. But child a bit difficult to give oral medication sometimes, especially smaller child. So it's okay, you can give NAP budesonide 2 mg. Okay, step. Then reassess back. And the keyword that Hamizah highlighted was assessment over period of time in emergency department. Okay, don't just give NAP and then leave the child alone or with the parents. So it can progress to moderate and even to severe. Okay, for moderate and severe, even moderate, you can also try and or, meaning either one. Okay, if patient come in stridor at rest, a bit of mild recession, and you can try give budesonide. If still not improved, then you give DEXA 0.5 mg per kg lah. Okay, difficult for you to order stuff ni kan. Boleh bagi DEXA 0.3 to 0.6. And senang ingat, saya remember 0.5 lah. Kan, senang ingat. Okay, single dose. Right. If no improvement, then proceed to NAP adrenaline. Okay, severe is clear cut lah. I think severe usually terus bagi NAP adrenaline plus DEXA plus budesonide and of course your oxygen. Okay, the most tricky part I think for us that will make us quarter sweating is when you want to intubate a stridor child kan. Okay, memang you akan quarter sweat lah. Okay. Okay. Alright, so you want to intubate a child, a stridor child. This is very, very important decision lah. Even for emergency physician kan. Okay, so because why? That will go back to your history, differentiating whether it's a Croup or is it a epiglottitis or is it a foreign body. Okay, if the child come with a stridor but the child relatively okay, not impending, so-called impending that we love to use kan, impending collapse or impending arrest, then we should plan whether this child is need a emergency airway in the OT lah. The best is going to OT. So we try to minimize kacau-kacau dia lah kan. And too many people around, semua nak set line, excited, this child is stridor kan. So in fact, try to leave the child alone and try to minimize the child from going into stress lah. Nanti akan worsen dia punya airway. Because the risk, if you intubate epiglottitis, what will happen? The epiglottis is very friable, swollen kan? It can collapse and occlude your airway. Okay, that is the ultimate complication that we don't want to happen in ED lah. So must plan carefully what is our strategy to secure the airway lah. Okay, tapi kalau dah child datang memang dah arrest, very dah lembik and then no doubt have to attempt lah regardless of what. Okay. So I think for Croup, quite clear cut, history very fast, child relatively well, and usually respond to the budesonide or even the steroid lah. Okay, next, Hamizah, bronchiolitis. Any questions from the audience? Or anybody want to add anything from the floor here? Dr. Isa ada soalan?
Discharge with safety net advice tu apa maksud dia?
Okay. Tadi Hamizah, you want to try to
Yeah,
answer?
safety
Ishak,
net advice.
yeah.
Uh, Safety netting advice.
Bagi
Uh,
net kelambu ke apa?
tak, maksudnya macam kena, kalau yang saya faham lah, safety netting advice is kita educate the parents regarding dia punya progression of disease and dia punya severity lah. If macam contoh kalau child tu develop worsening symptoms, tachypnea, recession semua, memang reduce oral intake, then kena datang hospital cepat lah, sebab most moderate to severe patient
So
yang
so
bronchiolitis.
so Hamizah. Hamizah.
Ya.
So macam mana, katalah senario Hamizah nak discharge parents tu, apa yang exactly Hamizah nak cakap
Okay,
kat parents?
cakap bronchiolitis ni virus. So dia akan subside yang usually cakap dalam 3 weeks lah, up to 3 weeks. Tapi kena monitor child tu punya oral intake, dia punya breathing dekat rumah. So in case breathing, dia child develop rapid breathing, ada symptoms of recession, and then child jadi exhaustion, nampak letih, reduce oral intake significantly, more than 70%, then everyday punya input, and then output pun dalam 12 hours to reduce, no wet diapers dalam 12 hours, then to come to ED urgently lah.
Okay, basically safety net is, I think safety net ni you can apply not just for bronchiolitis. Any patient that you discharge ataupun anything that we manage the patient in emergency, there are safety net. Safety net ni maksudnya ada certain advices ataupun certain red flags that you inform to the patient atau inform to the colleague. If anything ada, so then the parents need to bring the child immediately to emergency department rather than wait ataupun pergi mana-mana. They have to come and seek help lah if anything happen. That is meant by the safety net lah, safety net advice. Give the parents what are the red flag. Contohnya AGE, kita bagi tahu patient. Kalau akan bagi tahu parents, if the symptom worsening and prolonged diarrhea, prolonged vomiting, child cannot tolerate orally, reduce urine output, then child become unwell, not active, so you have to come back. That is the safety net lah, what is meant by the safety net. Okay. Any role of bronchodilator in acute bronchiolitis?
Based on up to date, dia cakap no rules of bronchodilator or NAP lah. So dia tak suggest for bronchodilator, NAP or even any medication, just supportive treatment dengan oxygen if indicated.
How about NAP saline or hypertonic saline?
NAP saline pun dia tak recommend.
Actually, there's not much evidence on that. Tapi you have to understand that bronchiolitis and asthma is two different things. In bronchiolitis, by right, you don't have bronchoconstriction or bronchospasm. So that's why by right, bronchodilator, there is no role lah. Cuma in the event of you are not sure, I mean, this patient could be having, reactive airway disease, early manifestation of reactive airway disease, especially under the age of 1 year old. So sometimes there is a role in, we would give, if let's say for example refractory hypoxia or refractory bronchi, so we want to consider despite your not improving upon your supplemental oxygen or plus minus your NAP. Sometimes most of the literature they recommend you to do a bit of suction, nasal suction. Sometimes that one also can cause the child to be in respiratory distress. Okay, do remember that there is a role of nasal or even oral suction. Okay, for that to clear. So they have so much of mucus in their airway, so that also can lead to the child being tachypnea. Right? Okay. Okay. Next, Hamizah. Any more questions from the floor?
So cuma nak tambah yang bahagian bagi nap dengan suction ni, kadang-kadang it's easy to say jangan bagi, tak nak bagi suction. Tapi when you're faced with an anxious parents, doktor tak buat apa-apa kan anak saya batuk macam ni. Saya pergi klinik ni dia buat. Sometimes you have to pandai lah. You tak boleh cakap direct and expect them to understand. Sometimes you have to explain a bit further lah. Okay. And sometimes if memang dah distress sangat, bagi je lah saline sebab bukan kata saya nak suruh praktis macam tu, tapi maksud saya nak cakap bahawa sometimes it's easy for us to say oh jangan bagi ni, tapi parents lah yang biasa very anxious and you have to be able to understand and explain to parents tu lah. Sebab kadang-kadang bila kita tengok banyak-banyak patient, kita tends to alah tak payahlah bagi nap ataupun nak discharge kan, tak apa, dia batuk, kita tak buat apa-apa, tapi kita tak explain further. Macam tadi kan Hamizah cakap, the cough can last up to 3 weeks. If you don't tell the parents yang patient mungkin akan batuk-batuk maybe up to 3 weeks and gradually gets better, and parents mungkin akan after seminggu, doktor, anak saya tak berhenti lagi batuk kan, mai balik. So that's why kadang-kadang safety net or explanation about the progression of disease, what to expect is important. So ini kadang-kadang yang benda yang biasa kita, yalah banyak patient kan, especially kat green zone or Ilibay kan, kita skip benda ni lah. So bila patient tak tahu what to expect, of course datang balik lah. Or what to monitor. Kadang-kadang kita cakap kat patient je, monitor lah anak tu, kalau teruk mai balik. Tapi specifically kan, parents pun tak pergi medical school. So kadang-kadang benda-benda yang soft skill, the humanistic part of the communication tu kena lah kan. Walaupun masa medical school boring kan, ni yang part selalu tidur kan, communication skill, soft skill. Tapi tu je lah. Okay.
Yep. The post-discharge advice is very, very important for us. Cuma I understand time constraint is a major factor juga kan. Sometimes dekat Ilibay tu I know you're seeing abundance of patients, so very difficult to spend to one parent, especially parent yang very anxious. You need to tanya lagi. So yeah, you just this one is you will develop over years, over time. So okay, all right. Any more questions regarding bronchiolitis or Croup? Okay, so I think Hamizah, your slides are sweet and nice, easy to understand. Cuma some of your slides are a bit too wordy. Okay, too wordy. If you could apply the rule kan, 6 by 6 kan, 6 by 6 kan, 6.6 words in one ni, and then it's good for you to put a footnote on, macam you ambil kat mana kan, contohnya the table, put a reference on at the bottom. So anything that definition, management recommendation, ataupun table, algorithm, if you want to present, put a footnote dekat situ. Dari mana you extract the point. So kan people boleh quote, okay ni Hamizah cakap daripada journal of RCEM punya recommendation is like this. Okay. Alright. Any more question ataupun any other EP want to add anything? Dr. Mashi, Dr. Ayu, Dr. Rafiq? Tak ada? Or any MO want to share anything? Tak ada? So maybe next edition we can break further into approach to stridor, approach to wheezing in children. Okay, there are a lot more lah, epiglottitis semua tu. Okay. But after all, Hamizah cover quite okay, right, in the slide. Thank you, Hamizah. Or Bear, you want to add anything, Dr. Bear? Dr. Husna, I saw.
Nope, I've got nothing to add.
Okay. I think we can ask one of the MOs in the, although you are not turning on your camera. Saya pilih. Atirah Rahim. Tak, kita tanya yang Rezon ya? Atirah Rezon. Okay. Eng Jian Xiang.
Tak ada soalan, Doktor.
Tak ada soalan tak? I want to ask you question. Oh, Bila, sorry Bila, I tak nampak Bila. Bila. Razi block you Razi besar sangat, tak nampak. I tak nampak Dr. Bila dekat belakang. Bila, you want to add anything? Bila? Tak ada okey. Saya totally tak nampak. Okey Jian how do you differentiate between viral induced wheeze and acute bronchiolitis?
The difference is usually between we look at the age group.
All right,
Usually
good.
bronchiolitis. Sorry. Sir, can you hear me?
Cannot. Your voices are broken.
Oh, sorry, my line. I
Hopefully
was
not
outside.
broken in tears.
I'm outside now. Sorry.
Oh, you tengah makan?
Bukan.
So come again?
Accompany my mom for TCA.
Oh, okay. Right. So what are the differences between viral induced wheeze and bronchiolitis?
The main difference is the age group, doctor.
All right, good. What are the difference again? We couldn't hear you at the beginning just now.
The difference is usually bronchiolitis occurs in those less than 1 year old, usually like 1 month to 6 months. Then viral induced is usually above 1 year old lah, and they usually have a multiple episode of wheezing.
Okay. All right. Okay, so the main difference is actually the age group lah, like Jan Xiang say. Then both are also induced by virus kan. Mostly viral induced. Tapi the age group is ni. And then the cough a bit of different also. Kan? High pitch and a very tight cough from the the table ni yang habis yang tunjuk tadi. Okay. Pneumonia, some pneumonia ada rongkai kan, especially those that with bronchospasm bronchospasm. Okay. Alright, kalau tak ada soalan lagi? Any more questions? To Hamizah, if tak ada we proceed lah dengan journal kan. Oh dekat chat box ada ke? Sini, tak ada chat box.
Boleh je pinjam daripada situ. Dari situ je.
Oh.
Boleh remain.
Okay.